Arrived, we'll just take 2 more minutes to let everybody in, and getting the closed captioning set up. With welcoming everyone tonight to the Bread and Roses Feminist Research Colloquium, hosted by San Diego State University's Women's Studies Department. The event tonight is Feminist Disability Justice and COVID-19, featuring Joseph Stromando and Catherine Cloone Taylor. Just a couple of notes about Zoom. Most of us are probably experts at this point, but in order to prevent people invading our space in ways that we don't want, we've turned off many of the features tonight. You can, if you have any questions, send a chat to the panelists, and we'll respond if you have any technical questions. And as you're listening tonight, if you have questions for the panelists, we'll collect those and ask them at the end. But most of the other features are turned off, so please use the chat if you do have technical questions. We have closed captioning tonight provided by Erin Copeland. Thank you for that. And Erin, if we're speaking too quickly, please send us a chat and I'll remind us to slow down. All right, welcome. I'm going to introduce our speakers tonight and then give them the opportunity to do a short audio description. So my name is Jess Watcott. I'm an assistant professor here at San Diego State University in the Women's Studies Department. And I'm delighted to host two fabulous colleagues here, also of San Diego State University. First, I want to introduce Professor Joseph Stromando, who is in the philosophy department here at San Diego State University. Professor Stromando's interests focus primarily on the intersection of philosophy and disability, the philosophy of disability and bioethics. He has written more than 20 scholarly articles and book chapters on topics ranging from informed consent procedures to reproductive ethics to assistive neurotechnology. His current research is devoted to developing 2 book manuscripts. The first, under contract with Routledge, will address the ways in which the field of bioethics fails to address the moral salience of the social categories of gender, race, disability, and sexuality. The second book will offer a systematic, if limited, defense of the permissibility of using reproductive technology to choose to have a disabled child. When Dr. Stromando isn't working, you will find him spending time with his partner, 2 kids, and their canine companion. And will you give an audio description of yourself?
Sure. So I am a cis man with thinning dark hair and a dark beard. I'm wearing a olive green shirt and I have white corded earbuds in my ears. I have dwarfism and I am sitting on the floor of my bedroom, which is kind of dark, and there's probably some kind of Plato's cave dad joke that's in there somewhere that I could tell if I was more clever. And you can see in the background my green power wheelchair.
Thank you. Our second panelist tonight is Catherine Cloone Taylor, an assistant professor of feminist science and technology studies in the Women's Studies Department at San Diego State University. In addition to a PhD in philosophy, she has a BMSc in immunology and microbiology. She teaches and writes in the fields of feminist theory, philosophy of gender and sexuality, philosophy of science, critical disability studies, and bioethics. She is at work on a book critically exploring the science, ethics, and biopolitics underwriting contemporary medical efforts with aim at securing cisgender futures for minors, which includes both the management of intersex conditions under the disorders of sex development treatment model and the treatment of trans kids with so-called conversion therapies. Many publications. And before joining SDSU, she was a postdoctoral research associate in the program in gender and sexuality studies at Princeton University.
Hi. I need to think about how to actually, I'm terrible at describing myself, but I am a mixed race Black woman with curly hair that's kind of piled on top, and I have glasses and I'm wearing earrings with black feathers, and my background, which is really the thing I'm most excited about, is the bridge of the Starship Enterprise from The Next Generation. And I'm wearing a white blouse.
Thank you. I love audio descriptions, and I just realized I failed to give myself one. So this is Jess Watcott speaking again, and I am a white, non-binary person with short, curly, dark brown hair, wearing white AirPods, and I have a gray button-up shirt on with a black blazer over the top. I am sitting in front of my living room, and there is a fake stained glass window next to me. It's not a real stained glass window. All right, thank you everyone for introducing yourselves. So tonight we wanted to, I invited you to have a conversation about using your feminist disability bioethics frameworks of analysis for helping us to understand the current COVID-19 pandemic. And I wanted us to think both about, well, first of all, both of you were very prescient in some of your predictions that occurred early on in this pandemic. So I wanted to talk a bit about that and what were some of the things that you were thinking early on that have come true or maybe unfolded differently than you thought. And I also want us to then think about the future and what kinds of things do we need to be attending to and fighting for as we move ahead. So let me start with the first question. So I'm talking, when I say early on in the pandemic, I mean March of this year. Both of you were thinking and writing about the pandemic very early. Catherine, with your background in epidemiology, you were warning me and many others that this was going to be a long haul. I specifically believed that this would be over in 8 weeks. And you said to me, how honest do you want me to be? And that you also, prepared me and many others for thinking about the impact that this was going to have in terms of illness and morbidity, and that it was going to be a lot worse than we believed early on. And Joe, you as well, back in March, were using your training in bioethics to speak out about these early triage and medical rationing protocols that disability activists were worried were going to withhold COVID-19 treatment from disabled people and also might affect the ability of disabled people to get ventilators and other equipment that they regularly use. So I wanted both of you to talk about some of your early concerns and the signs you were reading back then, And also if you could talk about how feminist disability studies prepared you to make these early assessments.
Joe, did you want to go first, or?
I can, or I can let you, however
Why
you
don't you
wish
go
to.
first? I'm excited to hear what you have to say.
Sure. Okay. So in the early days of the pandemic, I obviously was already attuned to the situation of disabled people and the power dynamics around medicine and how those play out, generally speaking, for disabled people. And that was really the contribution that my training um, prepared me to sort of use as a lens to analyze sort of what we were seeing. So I'm a philosopher by training, and my mentor was a feminist bioethicist, Hilda Lindman, who was my dissertation chair. And when I was at the time that I was applying to graduate school, there were no philosophers of disability teaching bioethics in PhD granting programs, with maybe one exception. And so I applied, widely to a variety of programs, and found a home with the feminist philosophers. And it wasn't really surprising to me that that's the case, because feminist philosophy and feminist bioethics is all about power relationships, right? It's all about looking at a mainstream bioethical problem and asking, where are the marginalized people? What's happening to them? How can we look at this problem through the lens of social power? And so that prepared me to use that lens, both to analyze bioethical problems when it comes to gender power, but also sort of appropriately appropriate those methods to think about disability in bioethics as well. And so when all this started to go down, I saw some articles out of Italy, and how their rationing was happening in a really ad hoc way, where, to my knowledge, I don't think that there was much in the way of protocols, but their spike happened so quickly, and they didn't have the resources ready to go to treat everyone, that they had no choice but to ration. And I saw articles from the press talking about rationing according to age, not letting people even into the ER if they were over the age of 60, was one article that I saw. Um, and as well as there was one piece out of Spain, which had sort of a similar situation in the early days, where all of the staff in a nursing home just left, and they basically, after the fact, found a building full of critically ill and dead people with disabilities and elderly folks. And so, seeing that happen in Europe, that got my attention, both in my own self-interest, because I am high risk myself because of my various disabilities, but also because of my community and people I love, and just because I'm a bioethicist. And so I started sort of looking at what crisis standards of care said in the United States, and how those may or may not be implemented if we were to have a situation like Italy. And so I also very early on got into contact with a friend that was is the legal director at Disability Rights Washington. And of course, we know that a lot of this stuff started in the US anyway, in Washington state. And so Disability Rights Washington, which is an amazing organization, was right on it, and looking at the crisis standards of care that were coming out of the state of Washington and the rationing protocols that they were modeled off of from the University of Washington's health system, and noticed some very troubling things. And so he actually called me up and said, "Hey, what kinds of arguments do we use here? How do we push back on this?" And so we that was very early on in the pandemic. That was before SDSU closed down and so on and so forth. And so he really got me fired up over this, I guess, and started thinking in terms of what I could do personally, rather than just sort of write ragey Facebook posts. And so I started looking at the different standards in different states and how they had really ableist assumptions embedded in them that would deprioritize disabled people in various ways. Some of them were extremely explicit. There was one in Alabama that had sort of categorical exclusions of entire groups of disabled people, talking about sort of diagnoses that if you had it, you just sort of would be automatically deprioritized or disqualified from receiving intensive care. So there were those really explicit ones. The ones out of Washington were more subtle, and those talked about health status as a consideration that was sort of over and above survivability. And so when you're talking about crisis standards of care, you have sort of the normal way to do things, which is to look at survivability as sort of a criterion for triage that basically asks, to the best of our knowledge, what is the likelihood that this person will survive this kind of illness, and then prioritize accordingly in an attempt to make sure that you are using the resources that you have in a way that will maximize lives saved, which is itself controversial in some sense, but at least isn't as egregious as using sort of health status or quality of life considerations. And so that that is what was happening in Washington as far as their protocols, where they talked about how they want to measure the acceptability of using scarce resources, not only in terms of how well someone is likely to survive as the health outcome, but whether or not they would be likely to survive without any disabilities. And so what that does is, if you already have a disability, that puts you at the back of the line, right? And so that seemed to me to be a slightly more subtle way of rationing out disabled people. And so it was these kinds of concerns that came to the foreground when I was looking at what could happen in the U.S. In the early days.
Yeah, thanks, Joe. I remember I remember those early days when you and I were like ranting about various things on Facebook. And there were a lot of things that I became concerned about right away. And so I should say, by my background, I have a background in microbiology and immunology, and a lot of that ends up, as part of that, you end up looking at a lot of epidemiology. And then I trained as a feminist philosopher of science, and who does situate her work within disability studies, but also some of the things that I should say other kind of important things that came to bear on the way that I was thinking was also that I am someone who is from Canada and was trained in Canada. And so come from a place that has a different approach to and understanding of healthcare as a right. And so a lot of my immediate concerns had to do with issues around health insurance, and how that was going to affect things here. But I also was reading the epidemiological information, and as kind of like a critical intersectional feminist, I am always first thinking about, how is this going to disparately affect people who are going to be disproportionately affected? And so I'd say, early on in March, I started thinking about a few things, and I'll kind of identify three, really. I think these were the three things that started or the three sets of things I started having a lot of anxiety about. So one of them was specifically about how COVID was going to work out in the US in light of a for-profit system of health insurance, a market-based system of health insurance, sorry, I should say, that is tied to employment. Because one of the things we know is that there is differential access to health insurance and health care subsequently, and that these disparities play out along racialized and class lines, right? And so folks who are likely already more vulnerable, right? Like folks who are more likely to not be able to work from home, to be in frontline work positions, are the ones who are subsequently most vulnerable to exposure, but also have the least access to medical care. It also, one of the things I started thinking about quite a bit was the fact that it was clear that many people were losing their jobs, about to lose their jobs, going to lose their jobs in the next few months. And that also meant that those were people who were going to be losing access to health insurance and healthcare, right? So one of the things I think we often talk about vulnerable populations, and I think problematically, we tend to associate that with people who are elderly or who are disabled, as though that is actually a kind of dynamic, fluid group, right? And so much about what makes a person vulnerable or not, or the kind of risk they are facing, depends a lot on their circumstance and context, right? And so some of the things I started thinking about is like, sure, we can think about right now at the beginning, we have a group of people, a population of folks who we consider vulnerable for whatever reason. But as things keep going, more and more people are going to be added to this group, right? So folks who lose access to health insurance and subsequently start having to ration their medication. So they're no longer as well as they once were and become increasingly vulnerable, or become increasingly vulnerable because they're not eating as much because they're having to try to stretch out their money as far as possible, right? And so I could see the way in which there were a number of systems that were going to break down, and that this would increase the number of people who were vulnerable over time, right? Or whether it was, and I saw this among my own students. I had students whose parents had been furloughed or lost their jobs. And so they went to work in grocery stores, right? And in a sense, we're increasing the chance of exposure, but someone's got to pay the bills, right? And so I one of the first things I think I said right in March was I was like, you need to nationalize your healthcare system right now, right? Like today, it should have happened a hot minute ago, but it needs to happen today, because we need people to actually get better, right? Like we need people to not be so afraid of the cost that they go to work when they're sick, right? Or not be so afraid of losing their job that they go to work when they're sick. And so I was thinking about it in that sense of, you know, the various kind of structures that I saw that could break down, that would increase individuals' vulnerability over time, so that that population of people we saw as vulnerable was going to get larger and larger. And I think we have kind of seen that. The other thing I was concerned about immediately was that it was very clear to me that this was going to disproportionately affect people of color, in large part because those were folks who are in those jobs that are frontline worker jobs. I mean, and also are disproportionately folks who are doing frontline care in hospitals, whether it's you know, aides who work in nursing homes or in hospitals, right? The people who are actually often doing the up close and personal labor are often low paid people of color who are often actually moving between facilities, right? Like, it's the truth. And one of the things that I think has been revealed in all of this is, like, many folks who work at nursing homes, for example, don't get enough hours for full-time work. And so they might have to work at multiple nursing homes in order to make a full-time wage, right? And that was how some of these vectors continued. And I was also aware of, like, you know, there were just so many compounding ways in which people of color are increasingly vulnerable, but they also are likely to have higher rates of chronic illness, right? Or of compounding factors that was going to mean that there were going to be higher rates of morbidity and mortality. And so that was one of the things I was thinking of. And the last thing I was thinking of was the, as you said, Jess, I was, right from the beginning, I was very nervous about how discussions around this were being framed in a way that I actually felt meant people couldn't make informed decisions, in that there was this kind of narrative of, okay, we're just going to shut down for a few weeks. It's just going to be maybe 6 weeks. Oh, it's going to be maybe 8 weeks. Oh, okay, maybe it'll be 3 months, right? Like, it just kept kind of extending a couple of weeks at a time. And it was very clear to me that that was not going to be the case, right? If we just look kind of at the history of pandemics and we think about the, you know, the traditional vaccine development timeline is usually about 5 years, right? And so it was clear that everyone was going to redirect efforts towards one thing, but there was a lot of knowledge and ground to cover. It was also clear to me how ill prepared the US was for this to happen, right? That there is a kind of playbook for situations like this. And I was also, you know, as someone who's interested in these kinds of things, I was up on the way in which, you know, the current administration had cut the funding to the CDC. And so I had a sense of how depleted the infrastructure was already for responding to something like this. And it was clear that we did have some lead time, right? Like, we saw what happened in Europe, but there was no preparation, right? Like, everyone was kind of pretending this wasn't really going to happen. And then when New York, I think seeing what happened in New York was the first time when we really realized, like, how quickly this could spread, and that, no, this wasn't a flu, right? Like, this wasn't a simple respiratory thing, that people were getting very sick and turning very quickly, right? And that was what you were hearing out of Italy when they had their surge, was that, like, you know, people were crashing fast. And that made clear to me that, like, not only just talking about development vaccine timeline, but understanding the pathogenesis of a virus takes time, right? Like, we're still kind of understanding how this works and what it does. And it was clear that it wasn't traditional, or wasn't kind of as simple as we might like to think about other coronaviruses, for example. And so it was clear to me that this was probably going to be a lot worse than we thought. Yeah, so those were the things I was thinking about at the beginning, was just like, we're not doing enough. we need to be ready, we need to be preparing, and here we are.
Yeah, I wish you weren't right, but you were, Catherine. Let me ask you, Joe, have you seen any successful interventions into some of those triage and rationing protocols since they first came out?
Yeah. Two things that I would mention. One is that thankfully, if you look at the data, what I was sort of most fearful of ended up not happening, right? In that, in most places outside of New York City, and a few other hotspots, we were able to flatten the curve enough that crisis standards of care didn't need to be activated. So in other words, we didn't actually have to ration ventilators and other, ICU beds and other kinds of life-saving interventions. And so that, of course, gave us time not only to develop the vaccine, but also to increase production when it came to things like ventilators and so on and so forth, and increase sort of capacity, which is a good thing. Now, of course, we're seeing numbers of infection rates at this point in the pandemic, where unfortunately, there is some chance that we'll see crisis standards of care activated, and we'll see infection rates being high enough that in certain places, there are sort of a lack of adequate resources to go around for everybody. And so this is still sort of a very present risk. As far as successes go, there was, I'd mentioned my friend at Disability Rights Washington early on in the pandemic that first started having these discussions with me about the triage protocols in the various states. He collaborated with a number of other advocacy folks, and across the country. I think the ARC was involved, and a number of other organizations got their lawyers together and brought a lawsuit with the Health and Human Services, Department of Health and Human Services, Civil Rights Division, to sort of request a federal level intervention in these sort of state level standards of care, and they won, which was great, and it happened pretty quickly, within matters of weeks, and so it's things like having categorical exclusions for disabled people from triage protocols were sort of preemptively discouraged, we'll say, by the guidance that came out from HHS. And so that was a big policy win early on, that happened through legal channels. But I think the to me anyway, more important win was less about lawsuits and what's legal and what's not legal as far as writing things into law, or into public policy, but rather sort of the level of consciousness raising that happened around these kinds of crisis standards of care and medical ableism. This is something that I study all the time, and to see sort of discourse around it be this pervasive in society in general was, to me, a win, right? where, you have people talking about, well, what if this gets bad? How do we decide who lives and who dies? And when you start having those kinds of conversations, it naturally leads to discussions about bias and discussions about ageism and discussions about racism and ableism and so on and so forth. And so having that kind of public discussion, I think, was in and of itself kind of a win, because it got people to recognize how vulnerability wasn't just a physiological thing. And I think that's something that Catherine was talking about, right? That's to be vulnerable to this virus isn't just about your comorbidities and whether or not you have asthma or diabetes or something, right? It's also about your social and political vulnerabilities and the ways in which society is structured to make you more or less vulnerable, that intersect with things like race and class when it comes to the frontline workers that Catherine was talking about, but also disability in terms of, a lot of this, a lot of the really horrific numbers as far as infection rates and death toll can be tracked to congregate care, and sort of large facilities like nursing homes, but also chains of group homes with shared staff. And so when you look at congregate care, this is an issue that the disability rights movement has been fighting for longer than I've been alive, as far as trying to get people out of institutions and get sort of resources and support to live in the community with their families and so on and so forth. It's when you have to live in a congregate setting in order to get your basic needs met that you are made vulnerable to something like a coronavirus. And so it's created a lot more urgency around this issue of deinstitutionalization. And so raising the sort of the public awareness and the discourse around institutionalization and ageism and ableism also, I think, was a win, in that, I saw tweets from bioethicists that, always are dealing with the sexy topics like, CRISPR or whatever, now about, long-term care issues. And it's like, where have you been the last 30 years talking about long-term care issues, right? And so, to see that was, pretty encouraging. I, of course, tweeted at them snarkily about, basically saying, where have you been the last 30 years? But yeah, and so, that, I think, just sort of the policy wins were important, but I think the battle of perception and the battle of sort of awareness was also an important thing. One more quick thing that I would mention also is that, unfortunately, the changes that were suggested strongly by HHS to the crisis standards of care at the state level could only really do so much when it comes to medical ableism around the coronavirus. There was one case that came out of Texas where there was this man, Michael Hickson, who was living in a nursing home after becoming disabled with a brain injury, I believe, and maybe quadriplegia as well, I think. And he contracted the coronavirus, and the crisis standards of care weren't even activated where he was. And he was denied care for his illness. And he was a man of color, and his doctor was actually recorded telling his spouse that they weren't going to treat him because of his very low quality of life. And she asked a clarifying question: do you mean because he has a brain injury? The doctor said yes, right? And so it's this thing around this assumption, this belief that disability is somehow worse than death, that is pervasive in American culture, that we see sort of play out in real time without there even being a crisis when it comes to medical resources, without there even being a scarcity that would require triage decisions. And so I think that as good as it was to see those kinds of legal wins, talking about ableism and how it's expressed in the clinic, I think to me was even more significant, because hopefully people can be more aware that this is a thing, and there'll be fewer cases like the Michael Hickson situation.
Thank you, Joe, both for bringing into the space the memory of all of those that we've lost this year, and also reminding us of the many movements that have been activated, and new ideas that have been made so much more real, or many more people believe that they're possible in this moment. I think there's something about the crisis that has made ideas that once seemed unimaginable, or people would say that's completely impractical, makes those more possible, I think. So thanks for that. So the last question I wanted to ask is for us to turn to what's next, I guess. I don't want to say the future because that seems too far away, but perhaps what's next? What kinds of things should we be fighting for right now? What kinds of things should we be organizing around, or what kinds of things are you aware of that people are organizing around that maybe you want to give a shout out and direct people towards?
Yeah. So I've been thinking about a few things, and given where we are right now, we're seeing an enormous surge. We're at the worst point in the pandemic than we've ever been, right? And I think I feel in a lot of ways like this Cassandra of like, which I felt like since March of like, there's these horrible things coming, and some of that has been borne out in really horrible ways. And I think unfortunately, I do think that things are going to get a lot worse before they get better. I think that in terms of things that I'm really concerned about, and I think we need to be fighting for, I think Joe was quite right that we were lucky that we were able to flatten the curve such that in a lot of places crisis protocols didn't have to go into place. I'm very concerned about us getting there, because I think we're already seeing a lot of places where medical facilities are at capacity, and so the things we were worried about before, I think might come to pass in that way. And so I think we need to be on top of it, right? And remember that even though there were these wins, right, I think as Joe mentioned, we need to still think that like that policy isn't actually going to be the perfect stopgap or dam that we hope it will be, right? Like that. Unfortunately, ableism has had a very long history in medicine, and it's not going to be wiped away with a few decisions. And so I am very concerned about that. I also think one of the things we really need to fight for is a kind of a fuller lockdown, to be honest, and one in which individuals are actually getting unemployment, where individuals are actually receiving some sort of financial support so that they can stay home and pay their rent and put food on their table, right? Like the idea that folks in the US got one $1,200 check since March is just unconscionable, right? Like we went into this, the thing that always kind of stuck out to me, and one of the things that always echoed in my mind right at the beginning of the pandemic was, going into this, it was the case that 40% of Americans couldn't handle a $400 emergency, right? And if you upped that to $500, it was almost 50%. And so many folks are working because they have to, and putting themselves at risk and being exposed because they have no choice. They need to feed their families, they need to pay their rent, right? And we have really not done anywhere near enough in order to actually ensure that individuals who are not multimillionaires can get by, right? Like those relief packages that have happened have ended up helping out those who least needed that help, right? And I do think that we need to really be fighting for that, because if we want to actually flatten the curve, we need to actually make it so that people can socially distance, right? Like recognize that social distancing is a privilege, and that, you know, if we're going to make any kind of real move here, we're going to need to make it so that social distancing is something that is possible for more people. And I think the other thing that we need to do is really recognize the importance of social distancing and the importance of doing everything we can for our physical and bodily health. But we also need to recognize that we need to also care for our mental health, right? For so many folks, this has been such a difficult year, right? Between the stress of COVID, I think the stress of the election, and we're now moving into the winter, right? For many people, where anxiety and depression is already higher. I think the relapse rate is up 30%. Domestic violence rates are up a similar amount. And so recognize that a lot of people are struggling, and we can't trade off mental health for physical health, right? Like we need to figure out how do we make both more accessible to people? And part of that is, I actually think for so many people, a good deal of the mental health issues they have to do with how vulnerable they've been left socially and politically and economically. And so, you know, if you can give folks a little bit more security, so you're not always like feeling like you're living right on the edge, and like, how am I going to pay for my, you know, my insulin next month, right? Like, it will be more possible for folks to find ways to make this livable. Because I also think, you know, there's been great news about vaccines in the last week or so, but we're still a while away from that helping everyday individuals, right? Or letting those of us just out in the world who are not, you know, first responders, who are not in some way or another frontline healthcare workers, getting access to a vaccine. And there's still a lot we need to know about vaccines, right? Or the vaccines that are being trialed. And so, you know, I think we need to think about this for the longer term than I think a lot of us wanted to accept. But think about, yeah, how do we make this livable for as many people as possible, while ensuring that as many people as possible, no matter what their race, no matter what their ability status, have equal opportunity to survive, right? Because you know, unfortunately, I think we're in a period in the pandemic where we're going to see a lot more death within the next 8 weeks. And I think we need to recognize that we are a society that has a real reckoning coming with grief, right? Like, I don't know that we've acknowledged the effects of what it is to have, in such a short period of time, have, you know, 250,000 people die. This is the largest mass death event that has ever happened in, you know, in the history of this country. And so, you know, I think thinking about our psychological well-being is something that we're going to need to attend to more carefully.
So there's so much good stuff in there, Catherine. Got me thinking in different ways. Let me see if I can capture some of that. I think one thing that we need to do is talk about the ways in which people are explicitly devalued culturally and politically within our country. Because, you know, this pandemic and our national response to it has become a partisan issue. You know, where you have people on the right, you know, denying the science, and using some of this partisan political discourse as an excuse or as a sort of safety valve for their mental health, right? Where they're just sort of they're themselves feeling the COVID strain, and in response they say, oh well, here's an easy way to deal with this. Let's just deny that it's happening, right? And so, you know, this partisanship is is deadly, but we have to recognize that it's not equally deadly for everyone, and that a lot of the rhetoric that we are hearing, either explicitly or implicitly, it devalues folks, right? When you hear people say things like, well, this only impacts people who are old, or this only impacts people who are already sick, right? Um, what does that say about how much you value those people, right? When you say that and then go out to the bar, what are you expressing about how you value those folks, right? And so we need to recognize the ways in which um, this has become a partisan political issue that is fundamentally grounded in a kind of eugenics, right? In a kind of belief that there are some members of society who are too weak to be of value, in a way, right? And so when we hear people say that, call them out, right? Sort of say, okay, well, you know, you're saying that this is, you know, only going to affect this segment of the population, but doesn't that segment of the population have a right to life, right? This, you know, we need to protect these folks through our everyday actions. So I think that's one thing to sort of talk about, and of course that intersects with race and class in all sorts of ways that we've already talked about, right? Which is also eugenic, right? And that's you know, when we're talking about the devaluation of people because of the bodies that we inhabit, the racism and the classism and the ableism mixed together for a death soup or something. I don't know. It's, you know, in which you know, they hook onto each other in ways, and this is, you know, this has been true for 100 years, you know, where the poor are unworthy of help because they don't have light enough skin, or because they might have some kind of defect that we can blame them for their own situation, whether that's physical or emotional or what have you. And so, we see this playing out now in terms of our response, our social response, and our attitudes toward the pandemic, and who is going to suffer disproportionately. And so I think having those hard conversations with our families about, their own behavior and the risks that they might be taking and who they might be putting at risk, and, talking to them about what kinds of attitudes might underlie their willingness to do that. I mean, those are hard conversations to have, right? But that doesn't mean that we shouldn't be having them. And so, as far as what we can do in our individual everyday lives, I would say that would be, one of the most important things, is to sort of talk about, how a lot of this rhetoric that we're hearing is as vile as it gets, even if it doesn't sound that way all the time, right? So I think, as far as policies, I would be, I don't want to repeat what Catherine's already said, but I would be remiss if I didn't mention again long-term care and congregate care. There has been an effort to try to get funding redirected to home and community-based supports and services for disabled people that would otherwise be institutionalized. And that effort has been going on for decades, but it is still going on now with even more urgency. There were pieces of the most recent legislation in the House that were specifically aimed at trying to get people out of nursing homes and psych facilities and large, group home settings, with greater urgency because of the pandemic, and with recognition that they are more vulnerable now to the disease. And so supporting those kinds of efforts in any way that you can would, I think, be really important, and could potentially save lives, because we talk about um, personal responsibility and personal choice, and talking to your family members about taking responsibility for not doing things that put others at risk. But the fact of the matter is, a lot of people don't have personal responsibility and personal choice because they are put in a situation in which they can't have control over how much risk they are experiencing, right? Either because of the kinds of considerations that Catherine was talking about, as far as having to go to work because you can't afford the $400 crisis, or because you live in a facility with a few hundred other people, with shared staff, in which a virus like this would just tear through. And so it's our responsibility to think about the ways in which our individual actions have an impact on others, but also the ways in which social structures can have an impact on how this thing spreads. And so finding that right balance to think about our advocacy efforts, I think is super important.
Yeah, thank you for that. You both touched on multiple layers at which people can engage in this question, ranging from conversations that people can have with their family and friends, all the way up to fighting for nationalized healthcare and deinstitutionalization. So thank you for that. We've got some questions that have been sent through the chat, and I just want to invite other folks, if you have a question, please direct it either to Heidi Doyle or myself, Jess Watcott, and we'll try to get to as many questions as we can in the next few minutes as we head towards wrapping up. So there was actually one question that just came in that I think is connected to what you were just talking about, Joe, in terms of congregate care facilities. And it kind of circles back to something that you brought up much earlier, Catherine, around the folks working on the front lines, providing care in hospitals and in congregate care facilities. And so I wonder if you can kind of circle back to those connections you were making in terms of, so the question asks, pondering about how capitalism and COVID, from a feminist bioethical perspective, and how value is placed on individuals based on their productivity, but devalues people working on the front line. So I wondered if you can kind of make some of those connections around how this pandemic is both making vulnerable people with disabilities living in care facilities and people with chronic illness, and also the people who are working on the front lines to provide care.
Yeah, so I might not fully answer your question or this question, but there is something I have been thinking a lot about, because I think one of the ways that I see capitalism acting here, and I think it's important to kind of note, is the way that it makes distinctions between the kinds of people who are frontline workers, right? So, thinking back to like the early days of the pandemic, how, we would go out and clang pots and pans for the hero frontline healthcare workers. But then as things kind of went on, though, we got a little upset that they might be asking for more pay, right? Or be asking for PPE, or be asking to be able to do their jobs safely, right? And, I remember hearing, and I'm sure others do remember hearing the stories about, healthcare workers who didn't have enough PPE, who were like living in their garage because they were so afraid of exposing their children. And we thought of these people as kind of selfless heroes, and we don't hear about those folks anymore. Though arguably it's not clear that it's because we've just solved the PPE issue, right? Or that it's because people are just doing fine, right? And so I think there's an interesting shift that has happened, even in terms of how we think of those frontline heroes who we think of, or those frontline workers who we think of as heroic in some way. And then there are other frontline workers who are the people who work at the grocery stores, who work at Starbucks. And what I always think of is the exemplar of, and I've heard this anecdote a couple times, of someone who goes into, say, a Starbucks, and the employee there says, I'm so sorry, you need to put your mask on. And then the customer says, I don't know why there's no one in here, right? Not even acknowledging that the employee is in fact a person, right? And so there are certain kinds of services that it seems that we just expect should continue to be available to us in ways that make our lives convenient. And I think one of the things that capitalism has done has kind of distributed those frontline workers in terms of value, such that we think some people should, just shut up and do their job and be happy that they have a job, right? And not without considering the kind of risk that we are asking them to place themselves at, in large part for our convenience, or so that we can feel like life is still normal in some way, when in reality it's not, right? Like, hundreds of thousands of people are ill, and you know, we're on the way to seeing many more die. So, and I think, you know, part of the problem here is this notion that we can't actually do anything, like there's nothing that can be done because the economy must continue, right? As though, you know, the economy doesn't actually require individuals to be alive, right? Like, as though it's not a problem for the economy if we have thousands of people die and hundreds of thousands to millions of people come through this pandemic with the amount of medical debt that will bankrupt them, right? So whenever we kind of talk about we need to kind of keep things over for the economy, my question is always like, what do we mean by the economy? Like, who do we think we're talking about here? Who is this helpful for? And I think really what we're talking about is ensuring that we actually don't have to support our citizens for the sake of the public good, or as though we don't have to acknowledge like the health of the citizens in the aggregate might in fact be a public good. And we don't have to do anything like, you know, support people so that they can stay home in order to try to flatten a curve, right? So, you know, I kind of think like where we are right now is it's like capitalism run amok, right? Like it's kind of peak the delusions of capitalism in a way, where it's like we're just going to keep going for the sake of the economy and not ever have to actually support anyone. If that makes sense. Yes.
I could take a shot at that question as well, just at least very quickly. So I'm not going to sort of look at it from a macro point of view, as Catherine was just talking about, but rather relate it back to this question of long-term care policy and deinstitutionalization. Because one of, I think in my mind, the most plausible objections to deinstitutionalization is the ways in which doing so would put the burden of care on family members, especially women, right? And so the argument goes that you know, when you deinstitutionalize, you know, folks are going to try to do it in a way that is going to save as much money as possible, and so you're going to provide as little supports and services in the home as you can possibly get away with. And so who's going to fill in that gap? Well, our, you know, our wives, our mothers, our nieces, our daughters, so on and so on. And so, you know, this is going to disproportionately, you know, harm women. And so, you know, and this is something that we are already seeing in the pandemic, in terms of the institution, if you will, of school, right? With school closures, you have kids at home, and it's, you know, not a coincidence that more women than men are leaving the workforce in order to care for these kids at home, right? Um, and so we don't want to then reproduce that problem by taking people out of nursing homes and taking people out of other congregate care settings in ways that don't provide enough support for them in their own homes, and they have to rely on others who are already struggling, right? So what's the answer to that then, right? I mean, I think that this sets up sort of a classic double bind that pits vulnerable people against each other, right? Where you have, you know, women that are, you know, marginalized by their gender roles pitted against disabled people, many of whom are also women, that have an interest in being, you know, let out of institutions. And so, you know, I think that we can, there's a way out of this, right? And that is to make sure that there's enough resources to actually do this, right? If someone is going to be receiving care from a spouse or from a family member, then make sure that that spouse or family member is paid for that work, right? And that will solve a lot of this problem, right? Because it will ensure that they aren't spread so thin and having to do so many different things all at once. And you won't have this kind of situation where a woman needs to leave her career in order to care for someone, because she will hopefully be able to either keep earning income through that work that is being done, or of course use that money to get the adequate supports that would be needed to make sure that her family member is cared for, right? And so I think that there are ways of sort of cracking open that kind of false dichotomy when it comes to long-term care policy.
Thank you for that. So we're gonna move towards wrapping up, and I'm sorry we'll get to everyone's questions, but there is one question I think would be great to end on, which is about whether you want to give a shout out to any resources, organizations, films, blogs, organizations that are doing some of the work that you've talked about, that folks can follow up on if they want to continue to advocate against some of the things that you've talked about and for some of the things that you've talked about.
You've kind of put me on the spot here. What's 100% going to happen is as soon as all of this is done and I leave this meeting, I'm going to think of 10 answers that were better than what I gave. So the first thing that came to my mind, one of the things that I am thinking a lot about and quite concerned about is folks being able to afford their medications right now, given that a lot of folks have lost their jobs or had to take on work that doesn't provide benefits. A lot of, as we know, a lot of medications are in general unaffordable in the US, and many folks many folks in the US rely on getting medications from Canada or from Mexico. And with those borders closed, they've been cut off from those options. And so one group that you might want to look into is a group called Insulin for All. It's a group that's helping folks access insulin during this time, and doing a lot of lobbying to try to get the prices of insulin decreased. I think that, if you can find ways to support organizations that are supporting folks with disabilities, I think that's really kind of important. And also organizations that are supporting folks who are victims of intimate partner violence. As I said, intimate partner violence is something that has risen in the context of the quarantine, and there are a lot of organizations that I think are very much in need of resources right now to help folks who are attempting to leave the situations that they're in, because a lot of people find themselves, who are in intimate partner violence situations right now, or might find themselves suddenly financially reliant upon and trapped with their abuser. So those are the first things that came to my mind. But Joe, go right ahead. Of course, as soon as this is all done, I'm going to think of so many. Anyway.
Yeah, me too. First of all, I just saw what Jess put in the chat, and I want to thank them for that. Liat Ben Mosh, I'm not sure if I pronounced that right, but is a brilliant scholar who works a lot at thinking about and writing about and talking about the intersections of the various kinds of institutionalization that disabled people experience, from incarceration in the prison system to nursing homes and everything else. And so, yeah, absolutely, Liet's work is critical. Another person or resource that I would point you toward would be Alice Wong, who you can follow on Twitter. She's super active, but also she has a wonderful podcast called the Disability Visibility Podcast. She has a new book out by the same title, and a blog that is wonderful. And so when doing sort of the kind of consciousness raising and that kind of work around thinking about how ableism sort of plays out in our social structures, but also in our everyday interactions, I would say that Alice would be a wonderful resource to thinking through that in a very intersectional way.
Sorry, just trying to post some of those links in the chat. So I think I got the Disability Visibility Project and another resource shared by Wes Palau from the Pride Center here at San Diego State University, the Trans Needle Exchange program. So was there another?
I was gonna say one more. I'm not sure. I haven't checked in on it recently, but there was a group in the Bay Area called the Disability Culture Club that was doing incredible work around all sorts of disability justice issues, but including sort of the pandemic early on. And one of my friends, Stacy Park, was very active in that, who happened to pass away at the very beginning of all of this. And so I'm not sure. I'm hoping, and I'm kind of assuming, that the Disability Culture Club is still active and doing work that is going to be helping the most vulnerable folks in Northern California, and really hopefully other places too. So that would be something that I'm going to check in on, and perhaps others want to as well.
Thank you so much, Catherine and Joe, for keeping it real, for being the Cassandras that we need, and also for doing excellent work to bring into this space the voices of activists, community organizers, which we're not always used to turning to in academia. So thank you for that as well. We're going to wrap up the event tonight. This will be was recorded and will be posted on the San Diego State University Women's Studies YouTube channel. I will send that out to everybody who registered tonight if you'd like to share it with anyone or watch it again. That information is also in the chat. And I wanted to say this event launched there'll be some more events on the topic of feminist disability justice hosted through the Bread and Roses Research Colloquium. We're actually going to bring Liat Ben-Moshe in March to talk about disability and abolition. She'll be in conversation with Subini Anima from Stanford University. And also working on an event to talk about the life and work of Stacey Milburn that hasn't been pinned down yet, but that is a goal because her life and work was so important. So thank you again for bringing into the room those of us that we've lost, those really difficult losses that we've had this year. So we'll be hopefully celebrating her life in the spring. Thank you to everyone who came tonight, and be well and take care.
thank you, Jess, for organizing this and for inviting me to participate.
Yeah,
Yes,
thank you.
Thank you. Bye, everyone.
Everyone. Good night.